the factors that are missing. Now, when we want to assess this system and see if warfarin is doing its job, we look at a prothrombin time. If I want to fix this problem, what I do is I dump back into the system the clotting factors that were previously missing. Hello? What happened? That was weird. Okay, so what I can do is I can say we're missing 2, 7, 9, and 10, and I can put those back in many forms. I could give you FFP, which is basically somebody else's blood concentrates and blood products, and it has those clotting factors in it, or I can give a more purified version of that. And most of us are familiar with a product called Kcentra, or a 4-factor PCC. Is there anybody who does not use that within your system? I hope in this day and age that is the primary way that you're reversing patients who've got a vitamin K antagonist like warfarin in the system. So PCCs, they're very fast at reversing INR, and that's expected because factor 7 interacts with the test that measures prothrombin time. So we're going to expect that as soon as we put factor 7 back into the system, we're going to get a reversal. But what we're more interested in is there a clinical effect for this? And the studies that have looked at this seem to show that there is a decrease in bleeding associated with reversing this drug, at least in the in vivo and ex vivo, and as close as we can come to real life situations. The cons for this is that there is a small thromboembolic risk and this stuff is not inexpensive. If I want to maintain sustained reversal, and I don't want to continue to give this person a $7,000 product over and over and over again until the warfarin goes away, I can simply try to give back the thing that is being inhibited, which is the vitamin K. And if I put that back into the liver starts producing normal clotting factors again, and I can go back to the ability to generate the products that I've been replacing temporarily using PCC or somebody else's blood, in other words, FFP. Now, when I get down to a different portion of the cascade with a lot of the newer agents that we're starting to see out there, we have a little bit more complicated problem because we are blocking these things at the linchpin areas here. So dumping in upstream factors isn't going to be all that useful to us, and dumping in downstream factors that are not activated is going to be problematic, potentially. So for the factor 2 inhibitors, we have dabigatran and Pradaxa, and that is a thrombin inhibitor. And I can get a general idea of whether or not that drug is present by measuring a PTT. However, the correlation with PTT is not nearly as good as the correlation with PTT and heparin is. So I can tell you that the drug is present, but I can't really give you a great idea of how anticoagulated you are, because at a certain point, that falls off the curve. But if I have a totally normal PTT, it is unlikely, not zero, but unlikely that I have any activated or any active factor 2 inhibitors in place. One of the ways that I can get rid of this is dialyze it. And the way to remember this with regard to which clotting factor or which anticoagulant can be dialyzed, the one that starts with a D could be dialyzed. The other ones are highly protein bound and not eliminated enough through the kidneys, so that doesn't work quite the same way for rivaroxaban, apixaban, edoxaban, etc. Now there is a specific reversal agent that is now out there. People have probably heard of this. It's pronounced adairasuzumab. And in order to get that pronunciation correct, I had to go to the manufacturer and ask them, how exactly do you pronounce this? And they said it's pronounced Praxbind. And I said, oh, I get it. Okay. But for everybody else in the world, it's adairasuzumab, and it's a monoclonal antibody to the drug itself. Very, very effective at doing what it's supposed to do. It's very good at removing the drug from the system. It works very well. The bad is that anything that ends in OMAB, EMAB, UMAB, or OMAB, that's all Latin for really freaking expensive. So you have to be able to understand that there is a cost to these kind of drugs. The unknown is, this is the big question for all of these agents, does the removal of an anticoagulant really change the actual outcome? It may slow down bleeding, it may normalize various parameters of bleeding, but does it really change the outcome? And we don't have studies to evaluate that yet. Next big question is, when do I pull the trigger? A simple bloody nose versus somebody who's got a spleen laceration. That has not been completely worked out yet. We can guess it's probably going to be the patient who's got the more serious bleeding, but we still need clinical experience with these drugs in order to be able to come up with a good protocol as to how to use them. Now, if you didn't have that drug available, and some pharmacies in the area have decided they're not going to stock a drug that's that expensive, there are alternative agents. And this idea of putting in 4-factor PCC or activated PCC, something called FEBA. factor VIII inhibitor bypassing activity. That's just basically PCC with activated clotting factors. The idea in here is I have a circulating inhibitor, and if I throw enough clotting factors in there, I might be able to overwhelm that circulating inhibitor. Very different from like warfarin, where we're trying to replace something that is not present in any significant quantity. Here I'm overcoming an inhibitor. If you did not have a daratumumab available, you could use activated PCC or FIBA, and that's the recommended thing to use in the absence of a daratumumab. Dosing 50 to 100 units per kilo. If you needed to know that, you could look that one up. That would not be hard to find. When we talk about direct 10A inhibitors, we're talking about rivaroxaban, apixaban, edoxaban, matrixaban, and you guys probably are most familiar with Xarelto and Eliquis as the trade names for these particular agents. And they do not require any intermediate function like with antithrombin. They are direct inhibitors of factor 10A. Therefore, if I want to measure their activity, I can measure anti-10A activity. I don't send that out of the emergency department currently because that is not a real-time test. However, in the next year, you're likely to see assays out there that are available that will tell you what is this person's anti-10A activity. So before I pull the trigger with a reversal agent, I know that the drug is in their system in an active concentration that is causing anticoagulation. Stay tuned for that. So the drug of choice for now, until the specific antidote is widely available, if you had to look at these two things, and they have been studied, most of the societies for hematology and trauma and all these other places will recommend that we use a 4-factor PCC like Kcentra in the absence of a specific reversal agent. Now, we do have a specific reversal agent now. It's not quite fully yet implemented in most hospitals, and it won't be for a while due to cost. But let's look at whether or not PCCs really work. This has been looked at in a number of studies, and they have shown in various studies that you can change some of the markers of anticoagulation, and you can occasionally increase endogenous thrombin potential, but there's no conclusive evidence that bombarding a circulating inhibitor with a lot more clotting factors that are nonspecific is really going to answer the question. So this is up in the air a little bit for now. The one thing that they were able to show pretty convincingly is if you have anti-10A activity and you put in PCC, you'll notice that the curves here overlap perfectly between giving Kcentra and giving saline. So we don't see any drop in anti-10A activity by giving PCC to patients who are anticoagulated with rivaroxaban, edoxaban, apixaban, etc. So the specific reversal agent is called andexanet alpha. The trade name is Andexa. Because of FDA requirements, the new name is called coagulation factor 10A recombinant inactivated ZHCO. I can't say all of those words and remember that, so if I'm going to talk about this in a generic term, I'm going to talk about it as andexanet alpha, because it just makes a little bit more sense. Theoretically, this is something that works on all anti-10A products, anything that binds to the 10A molecule, and it was approved in May 4th of 2018 for use, and it became experimentally used in a lot of hospitals in August and commercially available in the beginning of this year. Whether or not your hospital is going to stock it depends on a lot of different factors, including the ridiculously high cost of $25,000 a dose. Yeah, wrap your mind around that. That's like getting bitten by a snake and eating Profab or antivenom. That's very, very expensive stuff. So what it is a dummy factor that acts as a decoy. You break off the part of that that binds to platelets, and this becomes an inactivated factor that can no longer contribute to anticoagulation. But what it does is it finds the circulating anti-10A inhibitor and binds it up. So it acts essentially as a sponge to take this stuff out of the circulation. And does it work with regard to dropping the anti-10A activity? Yeah, within a minute or two of giving it, it drops the anti-10A activity very nicely. In fact, so well that as long as the drug is circulating in your system, it works. However, the protocols for using this drug only include an infusion for 2 hours, and after that point, the reversal agent andexanet is removed, and then anti-10A levels go back up. And you might think to yourself, why could that possibly be helpful? Because in the absence of an anticoagulant and a procoagulant stimulus like a laceration or a bleeding area, it only takes about 2 to 3 minutes for you to start to form a clot, and then a couple more minutes after that for that clot to become stable. So could you do it within that 2-minute time frame? Yes. There were no thrombotic events when they did this in volunteer studies, like 150 volunteers. They didn't create antibodies to native factor 10, which was good, because you don't want to give somebody an iatrogenic factor 10 hemophilia. That would be kind of a bad thing to do when you give them a drug. When they did the actual study that was in real bleeding patients, they had a safety arm of 227 patients and an efficacy arm of 137 patients. And they were basically trying to rate these patients on who, did you get an appropriate clotting, and was this stuff able to actually stop the bleeding? The question they didn't ask is, does it change meaningful outcomes for the patients? That's the tricky part in all of these studies. What they found out is the overall mortality in patients who were anticoagulated with a bleed who received the drug was around 14%, and that is lower than the reported risk of death in people who are not treated with a specific reversal agent. Nobody developed antibodies, or at least antibodies that had any significant real function. Here's an interesting problem. 11% of the patients who received the reversal agent developed an inappropriate thrombosis. That's 24 patients out of 227. And if you want to look at the comparison, how did this compare to the other drugs out there? Well, the study looking at PCCs to reverse 10A inhibitors, there was a 4% inappropriate thrombosis rate. And in the adagrasuzumab studies reversing dabigatran, there was a 6% rate. Does that mean that the drug is inherently procoagulant? We don't know the answer to that question yet, but there's one other factor that needed to be taken into consideration, and that is that the patients enrolled in the Andexanet study, 23% of them were on an anticoagulant because they had a blood clot pre-existing. That's why they were being treated. Whereas in the Kcentra group, there was an 18% risk of being on an anticoagulant for a procoagulant state. And with adagrasuzumab for patients who have a problem, only 2% of them were on adagrasuzumab for a clot. They were mostly on adagrasuzumab to prevent clotting from happening if you had atrial fibrillation. Different process. Those people are not necessarily procoagulant based on their genetics or based on an underlying cancer or something like that. So, did they work in real life with regard to dropping anti-10A levels? Yeah, they did. The clinical bleeding rate when using the anticoagulant reversal agent, Andexanet, was rated as good or excellent in a majority of the patients, and 100% of them had thrombin generation restored. But we come back to the good and the bad and the unknown. The good, it's very effective at reversing anti-10A activity. The bad, it's recombinant and brand new and costs $25,000 a dose. Wrap your mind around that, how you are going to convince your pharmacist to give this for a nosebleed. You got to be very careful and cautious about what protocols you set up so that your pharmacist doesn't try to take you out before you're able to pry that drug out of their hands. It's kind of scary. Is it thrombogenic? Maybe, but more likely it's not, but we don't know the answer to that question for sure at this point in time. Next question you need to understand is, when do you pull the trigger? Certainly not for minor bleeds, but in patients who have major bleeding. What is the timing from the last dose? The patient can reliably tell you that's useful. Could I use TEG in real time to be able to say, yeah, this guy actually took the drug and they're actually anticoagulated, as opposed to the guy who forgot the morning dose and now it's 12 midnight and they really don't have any anticoagulants in their system, but they roll into your hospital with a grade 1 or grade 2 spleen lac. Are you going to spend $25,000 in that setting? Is the short duration of the reversal agent an issue? We don't know yet because we haven't had enough clinical time using it. What about in patients who take an overdose of the drug? Not been studied yet. Could you make antibodies to the drug and create an iatrogenic factor 10 deficiency? We don't think so. We don't have evidence that that happens, but we don't have evidence that it doesn't in a very, very large population yet. And could you get anaphylaxis? Probably not. Could you use it in other cases? We don't know yet because the studies were limited to a very small population of patients in a very limited fashion. So what we're going to see is, now that the drug is available, you're going to start to see NIH grants and additional studies that are non-manufacturer sponsored that may be able to give you a decent answer to this question. But I want this to be on your radar because this is going to be in some of your pharmacies within the next few months. You got to know the pros and the cons, and there's a lot of stuff to read on this to be able to understand how this works. So hopefully you understand that you don't always have to reverse anticoagulation. You don't always have to anticoagulate somebody, but when it becomes necessary, realize we can tip the balance in one direction or the other, and we can throw them off in one direction or another. We need to understand when we should and when we shouldn't. Thank you.
Doctor, thank you so much. All right. I found this not working. All right. Up next, we have Dr. Mike Palacci coming up to the stage Dr. Palachi is the program director for the emergency medicine residency at Adena Health Systems. We're going to be talking about endovascular therapy for strokes. Dr. Palachi.
All right, well, Andy's right, that is right. I'm guessing that's not very flattering with my hairline. Try not to be too distracted by the glare. Thanks everyone for coming. Crazy excited to be here. This is a great venue, a great event that we've been planning for a while. And I've been following the activity on Twitter. So if you're on Twitter, please keep tweeting. There's probably 30 or 40 tweets while Dr. Kate was lecturing. Hashtag AllHalloween19. Put a couple out there too, but everybody tweet about girls is a great thing. Looks like they're just trying to get my presentation out there. Great, so endovascular stroke therapy. This is the shiny new car of stroke therapy. So there's not many people in the crowd who would understand what this is. Pat Hayes, you're out there, right? Pat might remember the Edsel. Wait a minute, why is this just... This is the wrong presentation, guys. All right, we're going to make this work. So the Edsel was going to be the greatest thing in automobile technology. It was going to bring the automobile to the common man, and it fell flat on its face. So the study that made everyone think that endovascular stroke therapy was going to be the next big thing in stroke management was PROACT 2 in 1999. PROACT 2 showed improved revascularization. It showed that you can reestablish blood flow to the brain, but it did not show any improvement in clinical outcomes. So it showed a DOE, a disease-oriented endpoint. We talk about those all the time, right? But it did not show any patient-oriented endpoints or an improvement in those. It didn't show any improved clinical outcomes, decreased mortality, decreased disability, etc. So over the next 10, 15 years, they kept trying, kept experimenting, kept tinkering. Some people still continued using the treatment even though there wasn't evidence of clinical benefit until we got to 2013. 2013, I apologize for the slides again, this is the wrong slide set, it's okay. In 2013, we got flooded data. 3 studies published in the New England Journal of Medicine in February. Mr. Rescue, Synthesis, and IMS3. These were heterogeneous studies that were all identical. They did have a lot in common. They were all industry sponsored. They all used a modified Rankin at 90 days as the primary endpoint. None of them showed an increase in symptomatic intracranial hemorrhage. The other thing they had in common is that they were all negative. No improvement with any of these studies. So the ESG enthusiasts at this point had all kinds of objections with the studies. They used the wrong timeline, they used the wrong device, they used the wrong this, the wrong that. Bottom line, as of 2013, we've been looking at this for almost 15 years, and at this point, there's no randomized controlled trial that showed any improvement in clinical outcomes for endovascular therapy for stroke. Then 2015 came. 2015 changed everything. Actually, it was late 2014 when at the International Stroke Conference in November, the results of this trial came out, Mr. Clean. Mr. Clean changed the trajectory of using this therapy for stroke patients. It's a big trial, it's a landmark trial, so I'm going to take a little bit of a dive into this. It was a randomized controlled trial of 500 patients in 16 centers in the Netherlands. To be included, you had to have a large anterior circulation stroke with a large vessel occlusion documented by either CTA or MRA. You had to have an NIH within 6, and you had to get to intervention within 6 hours. If you did that, 33% got to a modified ranking of 2 or less at 90 days compared to 19% of placebo. Number needed to treat 7. That is a pretty damn good number. We'll take that, right? You treat 7 patients, you get 1 better that wouldn't have got better otherwise. There was no increase in symptomatic hemorrhage, but one thing that was a little bit different about it, there was a little concern, was that about 5.5% developed a new stroke in a different distribution. Presumably from less manipulated clotting, if you want that to be insane or further downstream. So that was compared to about 0.5% for placebo. So the number needed to treat to get one better is 7, number needed to harm to cause another stroke in a more distal distribution of 19. Most people would take that trade. So that's very positive
trial, and it really shook up the EST board. And it caused panic, because at this time, in November of 2014, this was announced, published in January 2015, there were 6 other RCTs ongoing studying the same thing. So the people conducting these trials were like, oh my God, we gotta get our data out, or else we're gonna be irrelevant. So they all stopped. They all did interim analysis. They all stopped the trial and rushed to publish the results. And what we got was a rush of data over the next 6 months. These 2 trials, Extend-IA and Escape in March, and these 2 trials, SWIFT and RASCAT in June. Differences between these studies, okay, there was different time windows, some were 6, some were 8, some were 12 hours. There were some methodological differences, there were some differences in the devices used. Bottom line, they were all wildly positive, more positive than Mr. Clean. If you look at these MNTs, they're really, an MNT of 2, the problem with that is it's really tiny numbers. And we know that when we stop studies early because of benefit, we tend to magnify that benefit. And if you were to continue that through the completion of what your term-mediated power analysis, usually that really, really big benefit will regress down. Unless the probably still see the benefit, it will regress down closer to what you would expect. So, and then when you combine all these trials into a meta-analysis, which a couple people have done, now you're really making that exponential, because you're taking 4 different trials, 6 different trials with magnified benefit, and putting them together with the one. Regardless, 4 positive trials, and now this has been reproduced multiple times. Lots of momentum. Go forward a little bit further into 2016, we did 2 more trials. Now, what's interesting here is that the first 5 trials I told you about, tons of press, tons of enthusiasm, all published in the New England Journal with a lot of fanfare. These 2 trials, a little less. No media coverage. They were published in journals, Lancet Biology, and everything. But therapy was stopped early and did not show statistically significant benefit. It's the only one since Mr. Clean that has not shown benefit. What I found interesting about therapy is they told us in that trial that the reason they stopped was because, based on other trials, it was unethical to give patients to withhold this treatment from patients in use control. How quickly we got there. Thrace is interesting because this one was, other than Mr. Clean, was the largest study, had the most patients enrolled by the time they stopped. It was closest to completion. And if you notice, the NNT of 9 was actually higher than Mr. Clean. Now, don't get me wrong, the NNT of 9 for this is pretty damn good, right? But, what we talked about before, the smaller trials that were stopped early with fewer and fewer patients, gigantic benefit. The 2 biggest trials were the 2 largest NNTs. Not to say that that disqualifies it. The other thing is that all of these stroke trials, the neurology community, the stroke treatment community, the TPA sites, the DST sites, love the ordinal analysis. It's like the greatest statistical advancements in sliced bread if you listen to it. But in this trial in Thrace, when they did use the ordinal analysis, the statistical significance went up. Not a soul mentioned this. It was like a 1-sentence thing in a 10-page paper in the journal. None of the press coverage said anything about it. Just ironic how we can ignore it and want to really focus on the analysis there. Here's the next major development. This came in November of 2017. This is the second most impactful trial after Mr. Clean, because again, it changes the trajectory. The Dawn trial was done, was stopped after an early analysis of about 200, I think it was 206 patients. The Dawn trial looked exclusively at the extended window, at the wake-up stroke, so people that we've traditionally thought we have nothing to offer. So if you were under 6 hours, you didn't qualify. 6 to 24 hours to get into the Dawn trial. And their results are just mind-blowing. An NNT of 3 going out to 24 hours? I mean, that's incredible. So you've got to treat 3 patients to get 1 better. Out to 24 hours of people that we thought all we had to offer them was rehab. It's incredible. So this again was a sea change. This was a major advance. Like, holy cow, we can really extend this window. As we went into 2018, I'll tell you a quick story. Jesse Nichols is here, right? There's Jesse. And my favorite stories to tell. So this time last year, I was up in Michigan getting ready to give the extended version of this talk for the Michigan ASAP Ohio ASAP winter meeting. The night before, I'm printing out some notes and reviewing some stuff, and I see an email in my inbox from Jesse, one of our chief residents, that he saw an article on Medscape that day, the day before I was going to talk, that the previous day, 2 days before I was going to talk at the International Stroke Conference in LA, was this huge news-making day. There's a few things happening. Another trial that was ongoing, looking at the extended window, Diffuse 3, stopped early when the Dawn trial was published. And they released the results at the ISC. They went from 6 to 16 hours, and the results were wildly positive. So that was one thing, they presented those results. Simultaneously, as those were being presented, the results were published online. The other thing that was published online at that time was an updated guideline from the AHA and ASA based on all the previous studies, but also on Dawn and Diffuse 3. Before I get to what that guideline is, I'll take a look at this, borrow this from our keynote speaker, Salim Reza's Rebel EM website. It's a summary of all the RCTs for endovascular stroke therapy to this point. And what you'll notice with this, if you're familiar with Salim's website, you've seen these charts before, there's a similar chart for IVTPA, but is not painted nearly as green as this. This is, to me, is the biggest advantage, or the biggest thing to potentially get excited about this therapy, is that despite the flaws in the studies, it's reproducible. IVTPA has never done this. When you look at IVTPA, the chart's just about as big in terms of the number of studies, but there's only 3 that are green. There's a lot of red and a lot of yellow on that chart if you look at Salim's website. This has been reproduced since Mr. Clean. There's only been one study that didn't demonstrate benefit. And there was a benefit in that trial, it just wasn't statistically significant. So it's reproducible, which, again, despite the flaws, at least gives me a little bit of enthusiasm about the possibility of this will work for the select group of patients. So here is the new guideline. I'm not going to read it to you. The bottom line is it's a 1A recommendation within 6 hours based on Mr. Clean and a fully ability to follow. There's also a 1A recommendation within 16 hours if you meet the Dawn and the Diffuse 3 criteria. NIH will be 6, requires vessel occlusion, 6 to 24 hours. It's level 2A if it's within 24 hours. Reason being, they have a requirement to get a 1A recommendation to do 2 positive RCTs. Right now, there's 2 positive at 16 and under, but the only one that went out to 24 is gone. So if they get another trial out to 24, they'll probably increase that to a 1A as well. But for right now, it's a 2B. So let's pump the brakes for a minute, okay? Because there are some problems with these trials. And I'm not going to do a Jerry Hoffman impersonation up here and just gut them all, but I do want to at least make you aware of what some of the weaknesses are and what some of the reasons for causing it. So this was supposed to come up one at a time, but it didn't. It's okay. We'll go clockwise from the top left. Like we talked about, all of these trials except Mr. Clean and Dawn were stopped early. And we already talked about the effect that has on the perceived benefit. All of them were industry sponsored by the device makers who make the thrombectomy devices. They all use an ordinal analysis, which I'm not going to go into the details of here. If you're interested in that, take a look at MCRIT. Gloria Spiegel has done several articles on this that addresses this very significant problems with ordinal analysis. There was no placebo, lots of unconscious bias. The sites that were involved in these trials had true believers who were doing this for 10, 15 years before there was any trial that showed a patient one that was improved. One of them said he had to do at least 60 procedures a year to get enrolled in the trial. At that point, there was no data that it worked. So if you're doing 60 procedures a year when there's no evidence that it works, you're a believer. So that's going to lead to some unconscious bias in the interpretation. And these last two kind of go together. It wasn't blinded, it would have been impossible to blind. I'm not being, obnoxious up here. But when you combine the fact that it wasn't blinded with the fact that the modified Rankin primary outcome is a very subjective measurement that has very poor interrater reliability, there's a problem. So in other words, 10 people assess a modified Rankin, not all 10 are going to agree with the score is. So when you've got a subjective measure with poor interrater reliability, and the person who's assessing the score knows whether or not the patient got this medical treatment, and has some of that unconscious bias we're talking about potentially, that is a potential to maybe overestimate benefit. So these are all things to think about. But to me, this isn't the biggest concern. This is the biggest concern. If you look at this chart, this tells you the number of patients per center per year that were enrolled, that were eligible for this therapy. Now, Dawn and Diffuse, those numbers might be a little bit higher than they would be in a 6-hour window because they went all the way out to 24, right? But if you just do a crude calculation here, you come to about a patient per month. 1 to 2 patients per month. So another way to look at that is this. 1 out of every 770 patients with a stroke is going to benefit from this therapy if we look at these numbers. How's it come up after high school? Well, there's only one of these trials that told us how many patients they screened, how many stroke patients they looked at to get to the patients they enrolled. That was Extend-IA. Extend-IA screened 7,800 patients with strokes and enrolled 70. So about 0.9%, like 1 out of 110. Let's use Mr. Clean as a number needed to treat. It's the biggest trial, it's the cleanest trial, it's the only one that was C3 completion, it's a middle of the road NNT. Right? If you have to screen, if only 1 out of 110 patients with stroke are eligible, you got to treat 7 to get 1 better. We're talking about 1 out of every 770 strokes that benefits. But in order to get there, you've got to screen almost all of those 770 strokes. You've got to do a CTA or an MRA on every patient that has an NIH of 6 and meets those criteria. At what, a few thousand bucks a pop to do a CTA. You also have to change the EMS system to bring all of these patients to a center that has the ability to do it. And then you're going to be transferring a lot of these patients that are eligible to a center that has the ability to perform a procedure. See how the costs can rack up with this? Now, the societal cost and the personal cost of debilitating stroke are monstrous as well. But it's easy to see how the dollar signs can really start to explode if we're going to do 770 CTAs or MRAs, not to mention the investment in equipment and training and young health staff. It's really easy to see how that societal cost of the procedure could really start to really scale. Even that's not the biggest concern for me. This is the biggest concern. I don't know if you're familiar with the concept of the patient group or not, but I want you to put yourself in the position of an interventional radiologist or a hospital administrator. You've made this massive investment in equipment, in training, in on-call staff, setting up the lab, right? You're probably advertising it. We're going to do this great procedure that's going to make you play the piano, even if you couldn't play it before, after your stroke. And now you're going to tell me you're only going to do this procedure once every month or 2? Really? How's that going to go? Well, what is probably going to happen, actually what is happening in a lot of these centers, is the same thing that we're seeing happening with IV TPA. You're going outside the recommendations and pushing the limits and pushing the limits. And that's not always a bad thing. Maybe there's some other groups out there that might benefit from this. Okay? And the downside is relatively low. Except, we know in this population from the group of studies in 2013 that when you extend that indication out, it doesn't work. When we started getting all of these positive trials with Mr. Clean, when we really started being more highly selective in who we put in these trials. If we're not highly selective in who we put in, we're going to be doing a procedure on the same population that it was done on in IMS3, and Mr. Rescue, and Synthesis, and those trials were all negative. So indication creep for me is the biggest concern, not to mention the societal cost of only benefiting one patient out of over 770 stroke. That being said, for this highly selective group of patients, despite the methodological flaws, the reproducibility really makes me feel like this is potentially a great treatment if it's available. There's just huge societal cost at the tax bill. So here's a summary. I don't like to read slides still. I'll let you read that yourself. That's all I got. Thanks, everyone.
Dr. Palacio, thank you so much. Up next, we have Dr. Andy Little. Man, among many accolades, Dr. Little wears many hats. He's faculty on many national teaching initiatives. He's also a co-founder of the blog and podcast EM Over Easy. He's also the research director at Doctors Hospital right here in Columbus. He's going to be talking to us today about how we can share some bad news. Dr. Little.
All right. I gotta go. Richard, can you go back from the start? It's a nice preview of one of my slides, so it was going to be better timed if. Richard, great. Hold on. All right, so Mike Palacio owes me a pie in the face for getting this presentation wrong. giving me the wrong slides, but he did a great job bouncing back. So my name's Andy Little. Like Jeff said, I'm a faculty at Doctors Hospital, and I wanted to talk to you guys about something that's really near and dear to my heart, something that I've seen done wrong a lot. So, and that started from when I was a tech in undergrad, up through medical school, a resident, and even I was an attending. So we're talking about the idea of breaking bad news. So who here has had to break bad news in the last week? A lot of hands. In the last month? Okay, everybody's hand should be up, because you've had to give some kind of bad news, right? And so I really kind of want to debunk the idea that we have never been properly taught how to break news in the emergency department. All the literature available comes from oncology research, okay, which is where they set up family meetings. They say, hey, can you come in on Friday? Right? There's no coming in on Friday with a cardiac arrest. There's no coming in on Friday with a 4-year-old with pan-positive lymph nodes that has ALL. There's no coming in on Friday. So the idea that we've been taught appropriately how to break bad news is kind of something we need to realize, because we've never been taught how to do it from an emergency department standpoint. It's all been from primary care, from oncology. And the problem with that is that we have to break bad news so often that it's something that if you just start doing it without training, you're going to do it wrong for a while. And I had done it wrong for a while, which is why I wanted to put this talk together. So the preface in all this is that what we define as bad news is not bad news for everybody else. Right? If I was to poll everybody, the first day of residency, bad news for you is cancer and death. Unfortunately, any news can be bad news, because we don't know all the details of who we're delivering it to. I remember the first time this happened with me, intern year, Friday Night Lights, working on Friday night in October, had a really nice 17-year-old kid come in with what his coach said he had was a stinger, had altered mental status, had nausea, vomiting, negative head CT, so I actually spoke with his pediatric neurologist and said, hey, he has a concussion. So I had to go deliver this bad news to this kid, and I walk in the room, and there's new people there that weren't there before, and I say, hey, you just had a concussion, just broke it. You know, a very, very big intern mistake. And unbeknownst to me, he had had 4 previous concussions. He was a 4-star recruit, and was being looked at to get a D1 football scholarship. And one sentence ruined his future. So for me, this was benign, but for them, it was life-changing, right? And so any news that you deliver may be bad news, because you don't know where they're receiving it. So this is the typical family I think of when I deliver bad news, because this family can be delivered bad news in multiple ways. You could be telling this mom that they were driving home from this photo shoot and they got in a car accident, and he was the driver, and a drunk driver hit him and he's dead. You could tell this family that their youngest son has cancer, and the list goes on. All right, so this one family can get multiple different layers of bad news delivered to them over the course of their life. It's important to know how to do that. So how do we do this when it's awkward, right? Because there's no good time to deliver this. People they're already high strung, they're already at like peak emotions. It's where you have to give this in a certain way. And so when I was thinking about this, and I did look at some of the literature that was available and listened to a bunch of different talks. And to me, it came down to the idea that this is what we do in the emergency department. These are the most important discussions we have, next to discharge instructions, which is another talk. But the way we break this news matters. And so we should care about the way that we do it. So I'm going to give you 4 simple steps that if you follow will make delivering bad news significantly easier for you and for the people that receive it. Now these 4 steps do not include leave your cell phone at your desk. They don't include make sure you're presentable and not covering the Cheetos that you ate. Okay? Basic things. These are big blockbuster things you should worry about. So these are the 4 things we're going to talk about. The players, how to frame a conversation, breaking it, and then be present. So the first one is know the players in the room. Usually when we have to break bad news, we have been in that room multiple times. We've been there for the initial assessment, we've been there for follow-up, for a check-in when the nurses say the patient has a question, why it's taking so long. And typically we're going back, and over time, like things that happen naturally and organically, there becomes 4 or 5 or 6 or 7 people in this room. Right? Typically a significant other. Everybody has that super nosy sister-in-law that shows up around the hospital, or the aunt who's a hematology tech at some hospital 3 hours away who drives in. So you have to know who the players are. And so it's awkward, it might feel like first time, but I actually go in the room and I reintroduce myself to everybody. And I ask them, how do you know the patient? First couple times you're gonna do this, they're gonna be like, oh, what is he asking this for? You need to know. Because you need to know who the decision makers are, who the people that you're gonna rally on when you give the bad news to have family go to, and who you're gonna really wanna avoid when you're delivering this bad news, right? The next thing is you wanna reframe the conversation. So because there's new people in the room, they're not gonna know everything. So after you introduce yourself, you also want to include, can I share this information with everybody here? Because sometimes people will want to leave, whether the patient wants them to leave or the family members want to leave. And then you reframe the conversation. You start from the beginning of the encounter. So let me tell you what I learned about when we discussed earlier. Because they'll fill in holes that you might have in your story, and then you can fill in holes with our results. This gets everybody in the room on the same page to where they know what is coming. Right? And then you have to break the bad news. You have to use the word dying. You have to use the words cancer. You have to use the words death, if that's what's on the table. There's no greater disservice we do to our patients when we punt that to the inpatient team. When they get upstairs and the off-service resident who's on nights says, so hey, I guess you're here for your lung cancer admission. That should never be the first time they hear that word. We have to break that news. It sucks, but it's a part of our job, right? And then the hardest part is you just have to sit there. There's no prescribed time. I've been in a room as little as a minute, as long as an hour. You will get a sense from the feel in the room if there's enough family there that we're going to be positive and helpful, or if you're the only person that's going to be there. But be ready to be there for a while. Because the people, when they get this news, need someone to cry with, need someone to hold their hand, and need someone just to tell them it's going to be okay, even if it's not. And then the second part of being present is understand that being present is more than just one interaction. So I had to deliver bad news about a week ago to a family, gave them, the bombshell was in the room, reframed the conversation, told them, your father has cancer, and it's metastatic, and it's everywhere. We're going to admit you to the hospital, had the conversations, and about 5 minutes in realized I was no longer needed in the room. But I knew I would be needed later, because more people are going to come. There's going to be someone they're going to want you to call. The inpatient team's going to come in and they're going to want you there at the bedside. So always tell them that you were available and that you will be back. There are a few better words than somebody who has received that information than hearing from the doctor, I will be back. And I'm here until then. I tell them when my shift's over. Not so they can fall into my car and beat me up, but so they know that there is a time limit in which I'm there. And I always say, and I will stay as long as I need to until you get it. So these are simple phrases that make a big deal for patients. So again, the elephant in the room, this is not something that we are good at, right? This is something you should practice. When my residents have to go do this, remember they have to come watch me, I try to role play with them a little bit if they've never done it before. Because there are things you can and can't say, and practice a couple times, but also know that people are also very forgiving. If you screw it up, people are okay. They're okay with it. Because they also understand that you're in a bad place too. That you didn't go to work today hoping to deliver that diagnosis to them at that point. So have this be an opportunity where you can sit with your patients and their families, cry, laugh, joke, all levels of emotions, to make sure that this is an important conversation that they'll remember, and that they won't get admitted to the hospital and some resident says, hey, you're here for cancer. That sucks. We're going to get you to take care of it. All right? So again, remember who the players are, reframe the conversation, break the bad news, and then be present. If you do those 4 things, this will get significantly easier. Not that it ever gets all the way easy, but it makes it easier. And then always remember, any news may be bad news. I'll figure out the elephant in the room. You guys have any questions? If you don't, there are some references. If you guys want to take a picture of that with your phone, it'll take you to a blog post that I made specifically for this talk. And then that's the podcast that Jeff brought up. And that's it. Thanks so much. So we were going to take a quick break just to put up a panel, and then Jeff will come up and introduce them. But there's about 5 minutes. So if you guys want to go to the bathroom, grab something to drink, go say hello.
For those that are watching, we're going to take a quick break. We'll be right back.